Mary Leavitt, represent the 28th Legislative District, which is Western Pierce County. I serve on the workforce and post-secondary education, workforce development and post-secondary education committee on rules, appropriations, capital budget, and deputy whip, and really grateful. Oh, the other thing I would say about my district, Western State Hospital is part of my district, which is often a landmark that folks know. And so really grateful to be on here and serving with you, and look forward to learning from you and then doing some really good work, because we know we have a fentanyl crisis and certainly a crisis in terms of need in our state. Thank you.
Thank you so much. And then we also have our other alternate Representative Manjarrez, I believe is how you pronounce. So if you would like to introduce yourself real quick.
Thank you. So nice to be here. So I'm over here in the 14th Legislative District, which is mostly Yakima County, goes a little bit into Benton and Franklin and down into Klickitat. And substance use here is a very bad problem, just as it is all over the state. I guess my expertise in this is that I have a brother who's had a substance use problem his entire life. And so I have some real lived experience on what that does to a family, both his first family and his second family. And so I want to learn from all of you on how we really can help these people live a better life. And so thank you for having me.
Well, thank you for being here, and thank you for sharing your lived and ongoing living experience with substance use in your family, and just really appreciate you taking time, and hopefully this committee and the conversations we have will help as we all try to address this issue. Okay, we have some others to go through. So next I see Caleb Bantagreen.
Good morning, Caleb Bantagreen. I'm a representative of the Addictions, Drug, and Alcohol Institute at the University of Washington, where I'm a research professor, and I direct our Center for Community Engaged Drug Education, Epidemiology, and Research. And my work has primarily been with folks with opioid and/or stimulant use disorder for the past 30 years, both clinically in social work and then also in public health. My group is very fortunate to do a fair amount of implementation support and coordination with the Healthcare Authority and also with Department of Health. And I'm also a health services researcher and epidemiologist. So happy to be here. Thanks.
Thanks so much, Caleb. And it does not look like Don Julian Saucier is here, nor Sean Meyer. So I'm just trying to do this as quick as possible. Alexi Orr is not here either. Oh, Alexi is here? Yeah, Alexi, you are here. Sorry. Sorry about that.
Okay. I just popped in. Thank you. Good morning.
Good morning. Alexi, do you want to just do a quick introduction? Kind of your area of representation on the committee. Sorry if you missed it. We're doing introductions this morning because we have some new committee members.
Oh, sure. Yeah. Hi, I'm Alexi Orr. I represent adult with lived experience, and I reside in Eastern Washington. I work for the Foundation for Youth Resiliency and Engagement, which is a youth center serving youth 12 to 24.
And Alexi, thank you so much for being here. Amber Lynn Cope.
Okay, hi, good morning. Can you hear me?
Yes, you can.
Okay, hi. My name is Amber Lynn Cope. I'm currently working as the Outreach and Engagement Manager for Blue Mountain Heart to Heart over here in Walla Walla for the Recovery Navigator Program lead. But I'm not here in that capacity. I'm here as a member of the SURSAC committee representing certified peer specialists. And I'm just, I've been here since the beginning and just try to really bring a perspective of Eastern Washington and other rural communities. And also I'm a person with in long-term recovery from substance use disorder. So And I also have a brother who died of an overdose. So I have that lived experience as well.
Member, thanks so much for being here. Brandy Flood. And Brandy, if you're talking, you might be muted. All right, well, I did see Brandy put something in the chat, so we know Brandy's here, and thanks for being here. Stormy Howell. Okay. Sounds like Stormy also did an intro in the chat. Chad Enright.
Good morning, I'm Chad Enright. I am a Kitsap County prosecuting attorney, and I am here representing WAPA, Washington Association of Prosecuting Attorneys.
Thanks so much, Chad. And is John Hayden here? I didn't see John's name. I think John's here. How about Nikki Lewis? Nope, no Nikki. Sherry Condelario. Nope, no Sherry. James Tillett. Oh, I saw James. James, you want to say hi? Introduce yourself?
Hi, James Tillett, Outreach Service Provider Representative from Spokane, Washington. My experience is in addiction, living with substance use disorder, co-occurring. I've been in recovery now for 4.5 years, and I provide service in Eastern Washington.
Thanks so much, James. And Christine Lynch. All right, Sarah Gillard. Let's see, Sarah. Danelle Pinksley. All right, Malika Lamont.
Good morning, everybody. My name is Malika Lamont, and I'm on the SURSAC committee, bringing expertise around diversion and harm reduction to the table, and also have family members that experience substance use disorder and have experienced incarceration, as well as have lost many, many people, unfortunately, to overdose.
Thanks for being here, Malika. Addie Adwell. Let's see, Addie. Kevin Ballard.
Good morning, everybody. I'm Kevin Ballard, council member from the city of DuPont as a local government representative. Happy to welcome the new members of SURSAC, our elected representatives, and happy to be here. Thank you.
Thanks so much, Kevin. And Hunter McKim. Okay, so I think that's everyone. I'm counting 10, 11, 12. Looks like 13 present. And if there is anybody on the committee who didn't have a chance to introduce themselves, go ahead and do that real quick. Okay. Oh, Randy, I saw you come off mute real quick. Hey, Randy. Good morning. Thanks for being here. Did you want to do a quick introduction? I know you put that you were with Reach earlier.
Yeah, I was on a call when I couldn't answer. I was in the middle of a call, and then I had to switch from phone. My name's Brandy Flood. I'm the director from Community Justice for Reach. I direct our LEAD program, one of our case management programs out of LEAD. We work with unhoused individuals and people who are using drugs in the Seattle King County area and South King County. I don't know what else to say. For new members, Reach has been around for like 30 years. That's all.
Perfect. Thanks so much, Brandy. And of course, now that did take longer than I expected. So we're kind of running late on the agenda, and I actually had lots of updates for once. Well, I mean, I think each time I have some pretty good announcements regarding Healthcare Authority and other things going on. I'm just going to I'm going to put some links in the chat. Just I want to make sure everyone's aware of some key changes with the cabinet level agencies in Washington State. Governor Ferguson has appointed a new director for the Healthcare Authority. And I'll put a link to, it's not linking, but name is Ryan Moran. And Ryan's going to be starting with the Healthcare Authority on August 18th, I believe. And then also a new director for Department of Health, Dennis Warsham. And so I wanted to make sure that everyone had that information. There's a couple of announcements that came out of the governor's office that we can include in the notes. For whatever reason, I can't cut and paste them into the chat right now. But excited to have new agency leadership for Department of Health and the Healthcare Authority leading this important work. As we know, there's a lot of overlap between those two state agencies when it comes to substance use disorder, low barrier services, syringe service programs. And so, well, excited to welcome them and have them lead this work going forward. The other update I had was that WISIP, the Washington State Institute for Public Policy, published its report on effectiveness and on LEAD and Recovery Navigator program. This was required, just as a reminder, out of, it was added in 5536. There we go. And I can put this one here. And I put the link in the chat. This was codified, I forget the RCW, but it's the first report of a series of reports that WISIP will do looking at the effectiveness of programs like the Recovery Navigator program and LEAD, as well as how well they're operating with fidelity. And so I put the link in the chat, wanted to make sure everyone had that information. We'll also include it in the notes, but really appreciate the work that WISIP has done. They conducted a number of interviews with everyone that's involved with Recovery Navigator program and LEAD, from direct service providers up to agency and state agency staff. And so that was published right before the due date of July 1st. And then, if it's of interest to the committee, we can always see if somebody from WISIP could come and provide an overview, provide a summary, some of the key findings at a later time. And so be thinking about that and let me know if that would be helpful. The next updates, and I don't know how much time, because our next agenda item is at 9:25, right? And we still need to do committee member announcements and public comments.
You got 1 minute, Tony.
That's not gonna happen. I want in full, just to make sure that information is getting to the committee. I wanted to share that over the past couple of weeks, there's been a number of news articles. I say news, but there's been a number of articles covering the Safe Supply Work Group and the work that the Safe Supply Work Group did and the recommendations that came out of that work group. As a reminder, developing a Safe Supply Work Group to look at what a safe supply intervention would look like in Washington State, that was one of SURSAC's recommendations back in 2021, 2022. And as you know, as we've talked about, that work group developed its own set of recommendations and a legislative report. And there's just been a lot of incorrect media coverage on basically how the work group is being presented, and it's kind of being conflated with the SURSAC. And so just wanted to make sure everyone was aware of this. We did have our media liaison reach out to the entity that is responsible for these articles that I'm putting in the chat to try to correct some of that misinformation to no avail. And so we are tracking this. I wanted to make sure that the committee was aware of this, these articles, this media coverage of Safe Supply Work Group, and also share that we made an attempt to try to educate and kind of help delineate the responsibilities between SURSAC and the Safe Supply Work Group and how they're separate work groups, and also provide additional information about safe supply. So unfortunate to see some of the way that this is being presented and mischaracterized, and just wanted to make sure that I shared that. All right, I'm going to pause there because I'm already way over time. And just see, Blake, if you want to go through the next two agenda items, and then Teresa Winstead, thanks for your patience. We'll get to you in about 5 minutes. And so sorry for delay on there.
All right, you bet. Rep Leavitt, did you have a comment before we get into that?
I do, and sorry, I'm not able to, I'm in the car, so not able to jump on camera. I do have a question to go back to the previous comment about information out in the media that's incorrect, and the delineation between this group and the work group, and have many questions because it's not clear what's incorrect and what is truth. And so it would be helpful as a new member who hasn't been a part of these groups or made those recommendations to truly understand what's going on, and would appreciate some time. And I'm guessing Rep Burnett may want to maybe have a briefing on that as well. And I guess the other thing is I'm still unclear, are you disassociating yourself with the work group, or is the work group not part of this group as a subset, or I just don't understand that. So appreciate any understanding and learning I can get, because I certainly have many questions based on what I've heard and what's truth and what's not. Thank you so much.
Yeah, absolutely. And we'd be more than happy to kind of have a separate kind of summary meeting to kind of explain the history of all of the recommendations and help kind of draw those nuances. Specifically, this media coverage is indicating that the recommendations came from SURSAC, that the actual legislative report and the recommendations for a safe supply model derived from SURSAC. And SURSAC's recommendation was specifically to convene a work group. So SURSAC recommended that Washington State help support the convening of a safe supply work group. That was provisoed in the biannual operating budget a couple years ago. And then we convened a separate work group that was the Safe Supply Work Group, and that was actually facilitated by Health Management Associates. And so what's being conflated in the media coverage is basically saying that these recommendations for a safe supply model are SURSAC's recommendations, when in fact it's the Safe Supply Work Group's recommendations. So hopefully that kind of at least provides an immediate summary of what is incorrect, and then also happy to follow up offline and provide a lot more context. Go ahead.
Thank you. Just a quick follow up. So who does the work group though report to? Does it not? Is it aligned with this committee and then to HCA and then the governor? Who has jurisdiction over this work group, or are they just standalone on their own?
The proviso language directed the governor's office to appoint the work group.
But where does the work group align with? Where does the work group report to? Does it report directly to the legislature? And who staffs it and who has responsibility for it? This is what I'm trying to understand. Sorry for the questions. I'm just a little unclear. Appreciate your help.
Yeah, the funding was one time. So we no longer have, the work group is no longer being facilitated. It convened, and so it's no longer an active work group. It had one goal, which was to develop a set of recommendations, and that was published in a legislative report that was submitted to OFM, the governor's office, and the legislature. And then once those recommendations were submitted, the work group stopped meeting. And so the work group itself has sunsetted. During that time, the governor's office oversaw the work group, and the healthcare authority contracted with a third party for purposes of facilitating the work group and putting together the recommendations.
Thanks so much. It sounds like the healthcare authority does have jurisdiction over it, correct?
Well, I guess we have jurisdiction over the content that was produced. Yeah, but
And
the
the-
work group
and-
itself
and the-
is no longer.
Got it. And the staffing was from healthcare authority who staffed the work group?
We oversaw the contract with Health Management Associates. Health Management Associates staffed the work group.
Okay, thanks so much.
Yeah, good. Yeah, sorry about that. Context wasn't there.
Office chose the actual members though. Is that what?
Yeah. Okay, Blake.
All right. Yeah, you bet. Good morning, folks. My name is Blake Ellison, and I work in the Planning and Performance Division at HCA. And now it's time for committee members to make any announcements or comments that they have. So committee members, if you have anything you would like to announce, please go ahead and raise your virtual hand and we will call on you. Any committee members like to make any announcements? I don't see any hands. Last call. Okay, moving on to public comments. Public comments is a time where members from the public, non-committee members, can go ahead and make their comments around the work we're doing here. Committee. Lisa, go ahead.
Good morning. Thank you. Good morning, SURSAC members. I just wanted to flag the importance of long-term case management teams like those provided by the Recovery Navigator program statewide and LEAD and Arrest and Jail Alternatives programs in some of our communities as the state faces the ramifications of the Medicaid changes that are coming. Most of the projected losses in terms of people being removed from Medicaid rolls flow not because individuals are actually ineligible for Medicaid, but because of projected churn, where folks who are eligible because of a disability or otherwise fail to certify. So that is where long-term case management teams can be incredibly valuable to the state. And I just want to flag this for all of us, but especially for our legislative colleagues who are participating in SURSAC, because state impacts can lead to sort of a sense that we need to step back from other commitments in order to backfill these kinds of ramifications. And actually, some of the state's investments can prevent some of those, some of those losses by keeping people who are eligible on Medicaid. So some of the diversion programs that SURSAC has supported and that often report here, RNP, Recovery Navigator Program, LEAD, and Arrest and Jail Alternatives, are exceptionally good at maintaining that kind of connection to clients to be able to recertify and keep eligibility. And I just wanted to note that that's a strength we have to maybe help the state be more resilient in the face of those changes. Thank you.
All right, thank you. Thank you, Lisa. Any other members of the public like to make any comments? Okay. Thank you all. And Tony, do you want to introduce our next guest, Teresa?
Yeah, absolutely. Thanks so much. And Lisa, thanks for those comments. And, I know we have staff that are analyzing the final reconciliation bill and what those impacts are going to be on Medicaid recipients in Washington State. There is a report, a presentation that I can put in the chat which at least the House version of the legislation back in June, we do have an impact of federal proposals on Medicaid in Washington State presentation, and happy to have somebody come to a later meeting and talk about those once they've had a chance. Our legislative affairs team has had a chance to kind of fully analyze and summarize the impacts that bill is going to have on Apple Health and Medicaid within Washington. But thanks for your comments about the additional safety net those programs provide. Teresa is here with colleagues from UW's ADAI, Addictions, Drug, and Alcohol Institute. And just want to thank you so much for being here, and thank you for your patience. I know we had asked you to be ready at 9:25 and it's now 9:35. And apologies for that delay. And thank you for being here to talk about a new report that ADAI has put out. That when I saw that this report was published, I felt it seemed like something that the committee would be interested in. It talks about a lot of things that we've been talking about for the past several years. And so Teresa and colleagues and Allison and whomever else is here to support the work, thank you so much for being here, and I'll pass it over to you.
Thank you so much. We're glad to be here to share this new report about accessing harm reduction services and treatment supports at the same time. And Allison Newman is going to, I think, share slides. Allison. And we'll try to be sort of speedy with this sharing, but note too that we have a webinar where we'll share the longer form report and have more opportunity for discussion about this. So just note that there's a QR code to register at the end of the slides. So if you're really interested in hearing more about this, you can join us this week on Wednesday. And I'll hand it over actually to Allison to start us out.
Hi, thanks so much for having us here today, especially Tony. Thanks for inviting us after seeing the report. Really appreciate you having us at this meeting. So our report is, I think, one enhances the other, use of harm reduction and drug treatment among participants of syringe services programs. So our agenda, there it is. I like to start with a thank you because this work is really only possible because of the syringe services programs who hosted us to conduct these interviews. And I really want to send a thank you to all the participants who agreed to be interviewed for this work. These were half-hour to hour-long interviews, and people really shared a lot of personal and really important information with us. So this really isn't possible without the people who we talked to, as well as the programs who hosted us. And also thank you to the Healthcare Authority for funding this work. And I'll just make a note that although the Healthcare Authority funded the work, they did not have any editorial control. This is a product of our team at the Addictions, Drug, and Alcohol Institute. So what we looked at was, how do people use harm reduction programs, specifically syringe services programs? How do people use treatment programs? Do these ever overlap for people? And what do people think about using both kinds of support at the same time? And so we had looked at some of the literature and found that people talk about syringe services programs and treatment, but we know from talking to people that often they're using both, either one or the other at different times, or sometimes using both. And so we wanted to know what people thought about that and their experiences with those two types of programs. Methods, people had to be 18 or over, currently using drugs, which was any drug use in the last week, and have participated in drug treatment in the last 2 years. We conducted qualitative interviews using a semi-structured guide. So that was like a list of questions that we made sure to ask everyone, giving plenty of space for people to give longer form answers. And we could ask follow-up questions, and interviews were recorded and transcribed, and analysis was conducted using rapid qualitative methods, which we're really fortunate to have Teresa as part of our team, because this is really her area of expertise, is qualitative research, especially with harm reduction participants. So who did we end up talking to? We did 27 interviews, about split almost 50-50 between men and women. Average age was 42. Half of the people we talked to identified as being unhoused. The majority of people were white, with distribution across different races and ethnicities for the remainder. About half of our interviews were conducted in Aberdeen, with a good number also done in Shelton and Vancouver. So really important to note, we asked people what drugs they'd used in the last week. 100% of people had used methamphetamine in the past week, with 2/3 using fentanyl. A few had used heroin, a few benzos and cocaine. 2/3 of people only smoked. A quarter of people smoked and injected, and we had 3 people who only injected. Also important to look at, 41% of people's main drug was methamphetamine. 1/3 of people's main drug was fentanyl. We had a good number of people who said fentanyl and meth together were their main drug. So really, although I know opioids continue to be a cause of concern, I think this really highlights how prevalent methamphetamine use is, and really thinking about what that means for the services that we provide. All right, I'm going to hand it over to Leif.
Hi, everyone. Thanks, Allison. So this is a timeline that describes kind of the participant trajectory. So looking at the accessing syringe service program and treatment over time. And it's arranged by duration of years since the first time someone used drugs. So starting at time 0 would be when someone first used a drug, and then going all the way to the most recent treatment. So there are 3 data points that I'd like to highlight. First being the purple square, which is the first SSP access, blue circle being the first treatment access, and the green diamond representing the most recent time someone accessed treatments. And kind of the key takeaway here is that participants have a wide variety of harm reduction and treatment access trajectories, and very different durations of substance use. And on the left-hand side, you can see that there's significant distribution of ages from age 20 at the top to age 64, second from the bottom. So obviously different amounts of time that someone could have even been able to use drugs or access treatment. Next slide, please. So what I'm going to talk about today were kind of the aspects that were communicated by participants in terms of their perspectives and experience related to harm reduction. So first, we're going to talk about access to harm reduction programming and services, then services and benefits and motivations for why someone might access harm reduction or SSPs, and then kind of a few of the unmet needs and improvements that participants discussed. And I'll use harm reduction and SSP kind of interchangeably. So just want to give you a heads up about that. All right, next slide, thank you. So the first thing I'm going to talk about are kind of the experiences and perspectives around accessing harm reduction services. So as you saw on the timeline, participants had a great variation in duration of accessing services, as well as 20% began accessing in 2024. So kind of, like I said, a range. Half learned about the SSP from their social network, and others learned kind of by happenstance, walking by or in camp, outreach by mobile kind of access. And then transportation was kind of the main problem that participants indicated related to access specifically. Next slide, please. So getting into services, benefits, and motivations, there were 4 domains that participants described, and those were kind of related to drug checking, medical supplies, basic needs, and then just positive regards that all of these things that they received from accessing harm reduction services. And just to give you a heads up, some information about drug checking, if you're not familiar, it's a service that enables participants to bring in a small amount of substances they wish to ingest, to have them tested by trained technicians so that they have a better idea of what's in them and can use them more safely. And we have some quotes here as well that I'd like to read. So Around drug checking, I think it's cool. I think it's handy. It's nice to know what's in a drug. For medical supplies, I'm pretty sure that if it wasn't for this exchange right here doing what they're doing, I would either be dead or I would not have legs, because they're what kept me in my medical supplies so I can keep my wounds clean. So this exchange has been really wonderful. For basic needs, they said, I like the newer products. I didn't know were here. So yeah, like nicotine patches, toilet paper, the things you didn't expect to be here, like the antibiotic ointment, wound kits, etc. And like the allergy things and the antacids. Doing certain drugs may cause you stomach problems and whatnot, allergies. And then positive regard, just that I guess I get some positive interaction with somebody. For people that aren't demeaning or judgmental. It's one of the greatest things about dealing with the people here. And so, you know, those are kind of the really positive things that participants noted. So by and large, participants were very happy with their harm reduction programs, their SSPs that they accessed. However, they did kind of talk about some barriers to access, including kind of limitations in hours of service, consistency of location and transportation, which all kind of make sense given the mobile kind of unit context of these SSPs. And then thinking about some of the other services and improvements requested were dental care, relapse prevention support, hygiene services in terms of, you know, laundry or showers, things that they can use to clean or what have you, as well as injectable naloxone in addition to the intranasal naloxone oftentimes provided. And then this makes a lot of sense given that what Allison said kind of in the earlier slides about the substances that most of the participants used, so methamphetamine and fentanyl. So smoking supplies were something that many participants indicated what they were interested in, as well as kind of alternate access and service models. And I think with that, I am handing it off to Allison.
Back to me. Thanks so much, Leif. And I realized I should add that this report is really part of a body of work that we've been doing at CDER, where we do surveys every other year and qualitative interviews on alternate years. So I will put a link to those past reports, and really this builds on long-term relationships we've had with these programs. So we did ask people about treatment, their experiences, motivations and benefits, access and barriers, and their recommendations. And for treatment, we really defined it as substance use disorder treatment. Things included methadone from an opioid treatment program, buprenorphine from a healthcare provider. The one person talked about accessing it on the street, inpatient detox, outpatient, 12-step. And then one person mentioned using Vivitrol. And so really we heard from people who'd had a big range of different types of treatment. And one thing that came through was most people had tried substance use disorder treatment multiple times. They had varying lengths or of periods of non-use. So some people continued to use while they were accessing methadone. Some people reduced but did not stop their use during treatment. Some people had pretty long periods of not using and then had a recurrence of use. So a lot of this was really varied and individual.
Accidentally muted, Allison.
I got muted. Could you hear anything I said before?
We just missed a little tiny bit.
Okay. Oh, so lots to pay attention to. So people wanted to stop, reduce, or better control their drug use, avoid overdose and death, improve their health. People often wanted treatment to regain custody of their children or avoid jail. A few people talked about using treatment because it was required in order to access housing or shelter, or that it was required by the court. Benefits that they experienced the treatment were to learn coping skills, supportive staff. People talked about how access to medications for opioid use disorder provided stability. They experienced improved health and well-being while they were in treatment or after. Drawbacks that people described were pretty substantial and came up often pretty quickly. Rigid program rules, ineffective program staff, feeling like the staff wasn't the right fit for them or didn't have enough experience, that it was really hard to get into treatment, that it wasn't just an easy thing, difficult to access in terms of location or program rules or cost, the program not being a good fit, or involuntary treatment not being effective. So really, people really felt like treatment really only is effective if you want to be there. So in terms of time, I won't go too much into quotes, but I think the motivations is really powerful. This person said, I'm 20. I have so much time in my life that I don't want to waste out here. I don't know. It's not worth it. Chasing something that's never going to satisfy you. So I'm just tired of this lifestyle. I'm tired of these people, and I'm either going to end up in the grave or behind bars. And I'm not really trying to go to jail, and I don't want to die. And this was someone I interviewed who was only 20, but had tried, I think, 7 different types of treatment within the last few years, really motivated to stop using, but was not able to find, at this point, a program that was really working for them. This person talked about how the treatment really helped. They said, I went to treatment and everything I was speaking was confirmed by somebody really smart. So feeling like supported in the things that they knew they needed to do. A drawback that came up over and over was rigid program requirements, like getting kicked out for having a positive urine drug screen. So having treatment stopped if they continued or started to use again. So recommendations that people shared, that a one-stop shop would be helpful, and that came up more than once. People wanted easy access, including location or telehealth and affordability. People wanted flexible programs. Really, like the rigidity of programs was a real barrier for people who had really complicated lives. People wanted supportive staff, including people with lived experience, and really continued support after treatment ends. And handing back to Teresa.
Okay, I hope we're doing okay with time. Tony, please let us know if we need to wrap up. This last section talked about accessing harm reduction and treatment at the same time, which I think is part of what's really interesting about this data. So we asked people to talk about what they thought about using harm reduction or SSP programs and treatment at the same time. We asked them to reflect on information sharing, both from harm reduction service programs about treatment and treatment programs sharing information about harm reduction. And then we asked participants to think with us about accessing treatment at a syringe service program at a harm reduction site. Yeah, thanks, Allison. So this, in terms of harm reduction and treatment, we had more than half of our participants indicating that that use of both harm reduction and treatment at the same time would be beneficial. And this quote, I think, sums this up nicely. This participant says, quote, I think it would be pretty helpful to use both at the same time, having services to keep myself a cleaner version and going to treatment to learn all the coping skills and whatnot to do with cross addiction. That would help a lot. Go ahead, Allison. Thank you. However, participants also emphasized that the positive impact of harm reduction as a practical support would help them to decrease their drug use and access treatment programs. So really just that syringe service programs had a unique kind of support. So accessing them while while pursuing treatment was important. The first quote this participant shares, I think one enhances the other, which is the name of our report. The treatment, I feel like it was really hard to quit, but with needle exchange, it's like slowly weaning yourself down. They can work with you on decreasing your use and stuff like that. the second participant shares. I think it'd be good because, like I said before, it helps people having access to clean rigs and stuff like that, keeping some away from diseases and everything. So if they're still using, it's still a possibility. This was important in part because, as Allison mentioned at the beginning, people were really accessing, trying to get support for decreasing their use in very complex situations. So having access to all kinds of supports at the same time was something we heard over and over again. A kind of asterisk here, some participants also raised concerns about accessing harm reduction and treatment at the same time. We had about 40% of our participants sharing that this could be really hard and confusing. So this first participant says, I don't know. I don't think that mixes. You can't still be using it, and you either commit to it, meaning treatment, or you actually take steps to do it and you're just contemplating it. I think that's where that lies. And so I don't think it's a good mix. Participants mentioned challenges accessing harm reduction and treatment at the same time, like being back in familiar social networks where substance use was predominant. That sort of proximity and temptation was a part of what folks shared about that. Being reminded of kind of substance use rituals was challenging. And one participant talked about a kind of a physiological reaction to seeing a needle when she was trying to decrease her use. So just sort of thinking about the complexity of accessing both kinds of services and supports at the same time, I think is important just for thinking about the reality of navigating substance use.
Teresa, real quick, in that context, how were the participants kind of defining treatment? Like, I think in my mind, like they're talking about like traditional substance use disorder treatment, outpatient and or inpatient withdrawal management, like that full continuum? Or did it vary in terms of how we're like collectively talking about what treatment is in the context of this survey?
So that's a great question. Thank you. I think, people had, it depends in part on what section and what kind of set of questions we're talking about. Here, we're talking about accessing harm reduction and treatment at the same time. So, and people were talking about sort of traditional treatment often in this case, but also, that effort to decrease substance use and access treatment supports while accessing harm reduction. I think it means a lot of different things to different folks. So it was sort of a big list of potential treatment supports. I don't know if there's a really clean answer to that because each person had such a different experience.
That makes sense. Thank you.
Yeah. I think if in particular you were curious about a section or a quote and what folks were talking about in that particular situation, we could definitely track that down for you. But in terms of experiences, and I think this is something for all of us to keep in mind, the diversity of experiences and kinds of access that people are trying to kind of pursue is so wide that it's hard to answer that with just a like, it's always this. So yeah.
Thank you.
Yep. In terms of information sharing here, participants, again, really liked the idea of sharing information across treatment and harm reduction programs. So we had about over half thought that would be really helpful. And we have one apt quote here from a participant who articulates this really nicely. And they share, quote, I think all the information that a person can get. Maybe a person might not know, and they might come and see this, go to this program, and they see it, and information is power, definitely. Allison, you can go ahead. I think an important caveat here, just as I shared an important caveat before, in terms of information sharing, is that some of our participants, about 6 of them, noted that sharing too much information about treatment in a harm reduction context could be difficult, could be not great. So this first participant says, no, you shouldn't push anything on anybody. And the second participant shares, no, I mean, I guess to me, if somebody wants it and I don't want it pushed on me, and especially people that are deep in using, they'll stop coming. I don't want somebody who's constantly, well, are you sure you don't want to talk about this? Do you want to see this? Just suggesting that it could damage that really important relationship with participants in a harm reduction syringe service program context, to be promoting treatment without doing that really mindfully and really carefully, so that that relationship isn't damaged and stigma isn't conveyed. And then finally, we asked folks about accessing treatment services at a syringe service program. And more than half thought that this could provide benefits by lowering that access to treatment, that barrier to like finding a good match for treatment that our participants talked about a lot, and offering a more supportive and less judgmental kind of environment for access to treatment. I'll just read this top quote. This participant shares, quote, I would probably be more likely to engage with that treatment at a syringe service program rather than going to a treatment facility like I had before. It would be easier to do here. I'm going to say the relationship that we have with the people that run the program and the ease to which, I mean, I feel at ease here and I don't feel as judged. I don't know exactly how to express what I'm saying, but it's a less clinical setting. So really underscoring that what we know in other contexts, what we know from other work that that we've done in our group, that the relationships that syringe service programs have with participants is really strong, and accessing especially medications for opioid use disorder in that context could open that door and lower the stigma that a clinical barrier sometimes creates. And with that, I'll hand it over to Allison to wrap us up.
Thanks so much, Teresa. Just a few limitations to consider. The majority of people we talked to weren't housed, which may not be representative of everyone with a substance use disorder. We did not explicitly ask about other types of services, such as medical care or care navigation. Those things certainly did come up. It's a convenience sample where we talk to people who are available, who want to talk to us. And we only talk to people who are currently at SSPs. We didn't do the inverse, which might have been to talk to people at treatment programs about their experience with SSPs. So just consider those limitations. Some just quick summary, and then I don't know how much time we'll have for questions. For SSPs, people liked that it was easy to get there. They liked the staff, especially that they were non-judgmental, and the availability of essential resources that were hard to get otherwise. This especially came up around wound care and safer use supplies. Benefits of SUD treatment were to help reduce drug use, better coping, reconnect with family, and access to medications for opioid use disorder for stability. Although harm reduction and treatment have different approaches, most people felt these programs could be complementary and that using both had substantial benefits. People really wanted, most people wanted cross-pollination of these types of services, including having both types of services in the same location or education about both. Many people wanted to obtain treatment at SSPs because of lower barrier access. You know, you can just drop in, it's easy to talk to people. And people endorsed expanding access to low barrier and flexible programs where they could get holistic care and other supplies to meet basic needs. And this is just a thank you and links to our report. I really appreciate that Teresa made this QR code with a T-Rex in it. And please ask us any questions that you have.
Thank you so much. I'll get us started with the questions and just really appreciate this information. One question I had was on the slide where it kind of talked about motivations, barrier. There was like a motivation as well as another two other categories, and it said the motivating category was criminal court system, but then the barrier category was involuntary treatment. And I just thought that was interesting because Allison, do you know the slide I'm talking about? Can you go back to
I
it
do.
really?
Yeah, sorry for the speed driving the slides, but we're gonna get there.
Sorry, I should have asked the question at the time, but I wasn't sure if I should
That's
hold on.
fine.
Yeah, there we go. So a motivation is required by court or housing program, but a drawback is involuntary treatment. And so I was wondering if you had any thoughts about that,
Yeah.
because that kind of feels like,
By motivation for that, we meant the reason that they went to treatment. So why they went to treatment, which people didn't necessarily feel like it was always good to be court ordered or required by a housing program. So does that explain?
yeah, so
conflict
it's not like this is something that helps motivate me to okay, it's just saying like this is what happened that okay.
This is why I went. But thanks for the clarifying question.
Okay.
All right, we have a question from Rep. Leavitt.
Thanks so much, Allison and team. Quick question on one of them. I think you answered the majority. It sounds like we're unhoused, which is why they talked about having hygiene centers and showers, et cetera. Is that correct? And then a follow up. Okay. And then the second question has to do with treatment itself, because it sounds like several of the folks that you talked to have participated in some form of treatment. And so was there any deep dive into the nature of those treatment options that they participated in, whether they were short-term, long-term, 14 days, 7 days, 21, 28, were they public, private? Where were they? Were they in-state, out-of-state? So is there any information and data around the kind of treatment in which they participated in and the nature of such treatment?
I can answer that, or you can, Teresa, your call.
I think, go ahead, Allison.
Okay.
And I think maybe we can point to the report too. There's a little bit more about that in the report as well. Thank you for the question. Go ahead, Allison.
Yeah, thank you so much for your question. We did ask people what types of treatment, and I can just tell you that it was incredibly varied, that every type of treatment that you've described, someone had tried. We do have a little bit more information about that in this report, and I will say, because they're qualitative interviews where there are just 27 of them, it's likely not representative of the general trajectory. It's not necessarily like a prevalence type of thing, but people did talk about having tried all the different kinds and experiencing really a range of things. One of the programs where we did the interviews was in the parking lot of a methadone clinic or an opioid treatment program. And many of the people were visiting the opioid treatment program and then also visiting the Syringe services program. And people talked about how it was beneficial to have those co-located. I think we got more people who had tried methadone because of that location, but many people had tried inpatient. Many people tried outpatient. People had tried buprenorphine. One of the people we talked to said it was really challenging to continue their buprenorphine access because their clinic was far away and they had to take a bus. So just a real range of what people had tried. Let's see, it would be informative to talk to people who had received involuntary treatment about their willingness to engage in voluntary treatment in the future. Interesting. And yeah, Caleb was helpful to include some of our past survey information about what people had tried in the past year. But thank you for that question.
All right, any more questions? All right, thank you so much for the presentation. Very much appreciate it. Thanks for coming. Tony, do you want to introduce us to our next guest, Dan?
yeah, absolutely. And I agree. Yeah, thank you so much. I'll leave Teresa and Allison for being here and appreciate your
Thank
time
you.
and expertise. If there are any follow-up questions on the content of that report, can they contact you, Teresa?
Yep, absolutely. Please reach out, and I'll put my email in the chat. You can also reach out to Allison.
Thanks again. Okay, and next, we're introducing Dan Wendt from Mercer, who is here to talk about a rural access study. And just to kind of help provide the contextual setting, back in December and January, we did a couple of mural exercises with the committee trying to identify some kind of priority topic areas for 2025 and what those might include. One of those was around rural health, rural behavioral health, and access to services in rural settings. And I think this is going to be an ongoing conversation, especially as we continue to evaluate and understand the impacts from the federal reconciliation bill on Medicaid. But in the meantime, Dan is here to share the outcomes from a study that took place, I think, a couple years ago. And just really appreciate having a chance to meet with Dan last week and kind of talk about the study. A lot of it has to do with crisis response and crisis beds. And, as we know, that the crisis system is interwoven within the SUD system, and the individuals that we're serving through low barrier programs have often been in the crisis system as well and have had, engaged with mobile crisis teams. And so, really relevant content and information, and just appreciate Dan making time to share the outcomes of that study and take questions. So Dan, I'll pass it over to you.
Great. Thank you, Tony. And thank you to the SURSAC participants for inviting me to present today. As Tony said, my name's Dan Wendt. I'm a senior principal consultant with Mercer. I've been in this role for the last 14 years. Prior to Mercer, I had experience working for Arizona's Medicaid agency, as well as Arizona's Department of Health Services. I've also had some roles in some of the national behavioral health managed care organizations, mainly in quality management and contract compliance focus areas within those agencies. In 2023, Mercer collaborated with the Washington State Healthcare Authority. We performed a rural behavioral health access study, and I wanted to spend some time today to present a summary of our key findings and recommendations related to that study. I do want to note that Mercer has not been engaged with the Healthcare Authority to implement any of the study recommendations. And so any information about the status of follow-up actions is generally, I'm not aware of what the status is. We did utilize Healthcare Authority data and reports from 2022. And some of the legislative reports that we ended up synthesizing and summarizing as part of the report dated back almost 10 years. So the information that I'm presenting today may not be aligned with the current state of access to behavioral health services in rural areas across the state of Washington. Also wanted to note that while, and Tony described this in his introduction, we definitely touched on substance use disorder treatment services and access to those services, but the study was more general in terms of behavioral health services, and so it was inclusive of both mental health services as well as substance use disorder. I've tried to kind of highlight more of the substance use disorder treatment services when that information was available and it was came over as part of the study. So if we can, so what I'll do today is I'm going to provide some background information, a little bit of a description about the methodology that Mercer employed, and then focus more on some key findings and recommendations. Next slide, please. Oh, wrong direction, I think. There you go. So the rural access study was originally commissioned through legislative action. And it required the healthcare authority to examine challenges with receiving timely access to behavioral health services in rural counties. There were 4 focus areas that were emphasized, and those include designated crisis responder response times. And just for folks who may not be as familiar with designated crisis responders or DCRs, these are mental health professionals that are specifically trained to assess individuals that may be experiencing a behavioral health crisis and determine if they need to be involuntarily detained for treatment. DCRs assess whether a person meets criteria for involuntary detention under the Involuntary Treatment Act, or ITA. The ITA, I think, is sometimes referred to as Ricky's Law in Washington State, but it provides a legal framework for civil investigation, evaluation, and potentially the commitment of individuals experiencing mental health or substance use disorder conditions if those conditions pose a significant risk to themselves or others. Ricky's Law was expanded in 2018 to include involuntary commitment for substance use disorders in addition to mental health conditions. The other focus areas that we looked at included the availability of behavioral health inpatient and outpatient services, wait times for psychiatric hospital beds, and the availability of adult and youth mobile crisis teams across the rural counties. So to define rural counties, and for this study, we utilized the Washington State Office of Financial Management definition of a rural county, which is a county with a population density of less than 100 persons per square mile. So I think there are 39 counties in Washington State. Using this definition, we then included 30 of those 39 counties were part of the study. And then we also engaged with some of the behavioral health administrative service organizations. As many of you may know, there are 10 regionally based BHASOs who have behavioral health network responsibilities. Those include things like crisis hotline services, mental health crisis services such as mobile crisis, short-term substance use disorder crisis services, and those Involuntary Treatment Act or ITA assessments, and the administration of detention petitions. Next slide, please. So in terms of the methodology, Mercer reviewed crisis system utilization data that was collected by the BHASOs and some other behavioral health related reports that were shared by the Healthcare Authority. I will note that these reports that were made available to Mercer primarily included data at the RSA level and not at the county level. And because most of the RSAs include a combination of rural and urban counties, there are a couple of exceptions, I think, for North Central and Great River RCAs. The data at the RCA level reviewed by Mercer could not be attributed to specific rural counties. As such, we had to rely heavily on surveys and interviews with behavioral health system stakeholders to conduct a more thorough analysis. We also looked at some of the MCO and BHASO network adequacy standards that are in the Apple Health and BHASO contracts, just to see if those network adequacy standards were specific to rural areas and had different expectations for those more challenging geographic areas. We also analyzed survey data and interview responses from select behavioral health providers and other stakeholders. We developed a survey that targeted those 4 focus areas that I described, and we sent that out to over 50 recipients that we identified in collaboration with the Healthcare Authority. We ended up getting 11 survey tools back. Some of the groups of folks that we sent to consolidated their responses. We had responding agencies that included four surveys that were completed by the BHASOs. We had 4 completed by the managed care organizations. We had 2 come in from behavioral health providers, and we had 1 from a rural hospital that also completed the survey. Then we also followed that up with some targeted interviews with 2 of the BHASOs and 1 of the managed care organizations. And then late in the process, we kind of stepped back and started to incorporate some of the tribal issues that are also prevalent in rural areas. And so we convened a tribal listening session where we collected data and got to hear from those stakeholders. We also, as I mentioned, synthesized and reproduced information that was published in some recent legislative reports specific to issues experienced by tribal populations, including recommendations to improve the tribal behavioral health service delivery system, and we incorporated that information into the final report. Next slide, please. So this talks about the DCR response times. Again, these are findings that are derived from the surveys and interviews that we conducted. And I'm just going to kind of highlight some of the most common challenges with accessing DCR services or performing DCR responsibilities in rural counties. We certainly heard about insufficient staff coverage and a perceived lack of funding to recruit additional DCR staff. There's challenges with cellular phone service in coverage in remote areas. Obviously, the extensive travel time in remote areas can be a challenge. There's widespread stigma in some rural communities associated with individuals that may be struggling with mental health and substance use disorder conditions. This can result in some regions citing a lack of resources available to support folks, and some emergency departments being less accommodating to patients who may be experiencing mental health or substance use disorder issues. Recruitment and retention of DCRs in rural counties is particularly challenging. Often there's only 1 DCR per shift, which can delay access to services and burden the DCR to respond. Challenges to DCR employment or retention included finding affordable housing for behavioral health professionals in rural areas, and extensive training that's required before deploying a DCR. In the state's rural and frontier geographic service areas, the nearest city, as many of you know, can be over an hour-and-a-half drive, and travel time can render the DCRs unavailable for prolonged periods. There's also requirements to complete medical clearances in emergency departments before admitting a member to a hospital bed, or an evaluation and treatment center or secure withdrawal facility, or even a crisis stabilization unit, and that can pose a challenge as well. We looked at the data collection that the BHASOs were doing related to the DCR services. All the BHASOs reported they collect emergent DCR response times for rural areas, but only a couple of them are collecting for the urgent DCR response time. And just for folks to know, the Healthcare Authority defines an emergent response as within 2 hours of a referral to a crisis, and defines urgent responses as within 24 hours for a referral to a crisis. And then we looked at the average time, or inquired about the average time DCR spent on ITAs from start to finish, which was 386 minutes. Most of the BHASOs reported it takes longer to complete the ITA process for individuals in rural areas. Some of those reasons include the travel time, limited staffing resources to provide countywide coverage, and address multiple crises simultaneously, and the coordination of transportation and placement due to long distances. Next slide, please. So top challenges to offering a wide array of behavioral health services in rural counties. There's a pervasive lack of available behavioral health providers in rural areas, including Spanish-speaking providers. There's staffing shortages. It's difficult to attract and retain qualified providers to relocate and live in rural areas. Some rural providers experience protracted delays in filling vacant positions. We had one provider report 4 key vacant positions for over a year. Access to transportation and long distances between behavioral health providers and individuals seeking care. Some individuals must travel over 2 hours to find an available provider. And then provider reimbursement rates are perceived to be too low and to attract and retain providers in rural areas. Rates may not consider the unique needs of agencies that may be operating in rural areas. Again, transportation, which is not always reimbursable. Some behavioral health providers may opt to contract with commercial carriers as the reimbursement rates may be higher than those that are offered under the Medicaid program. The top behavioral health services with extended delays to access the service included Children's Long-Term Inpatient Program, non-emergency medical transportation, substance use disorder intensive inpatient residential, involuntary inpatient psychiatric, mental health freestanding evaluation and treatment, and medication management services provided by adult and child psychiatrists. Services that have wait times, many behavioral health services have documented wait times. They vary depending on the respondent and the county. That Children's Long-Term Inpatient Program, we heard information that can take anywhere from 30 to 90 days or even 6 to 9 months to access that service. No responding BHASOs, MCOs, or hospitals are tracking wait times for outpatient and inpatient services following an ITA. Only one of the behavioral health providers that responded to the survey tracks wait times for outpatient services. Next slide, please. Hospital wait times, bed wait times. Just to highlight some of the key findings here, respondents provided different reports of the number of beds available for youth and adults within their regions and statewide. We heard information that there are not enough beds for youth, especially for children aged 12 years and under. Only one facility available statewide at the time that we conducted the study. Most responded there are enough beds available for adults to meet the need. Some of the localities cannot access hospital beds and have to transport individuals that require that level of care outside of their region. I'm probably not going to pronounce this correctly, but Okanagan County does not currently have access to any mental health inpatient beds within the county. There's an increased prevalence of children with dual diagnosis or autism spectrum disorders. This can result in youth lingering in acute care settings with no intermediate levels of care available. Serving children with co-occurring conditions is more challenging when coordinating discharges of available funding with other child serving systems, such as the Developmental Disabilities Administration. We looked at the process to obtain a bed. At that time, there did not appear to be a standardized process to identify if an inpatient mental health or SUD bed was available. The BHASOs and the tribal IHCPs have to contact facilities all over the state to search for a bed. Sometimes they initiate single bed certifications or trying to find less restrictive alternatives to inpatient. Conversely, the continuum of available ambulatory services, such as the program for assertive community treatment or intensive outpatient services and medication monitoring, is insufficient to address the current demands or alleviate the needs for inpatient treatment. We collected the top reasons for a no bed report, and those include a lack of available beds, again, particularly for youth aged 12 years and younger, a lack of providers, lack of staffing, the level of acuity in terms of medical, behavioral health, and SUD needs, and a lack of facilities able to or willing to provide services with complex needs such as comorbidities and co-occurring disorders. Next slide, please. The last focus area was timely access to mobile crisis teams. All the responding BHSOs dedicate mobile crisis teams to rural counties in their regions. We looked at team composition and staffing. The crisis teams, mobile crisis team size ranges from 1 to 4 individuals per team, depending on the county. Many mobile crisis team staff members also have dual roles as DCRs. Some of the smaller counties maintain 1 mobile crisis team per shift due to staffing shortages, and some struggle to maintain 24/7 availability. There are current requirements for mobile crisis teams serving youth, require 24/7 availability. The teams must include at least 2 staff, irrespective of whether the team operates in an urban or rural geographic service area. Some of the BHASOs reported mobile crisis team vacancy rates around 30%. And then some counties have a team that can serve adults and children, although the BHASO reports that legislation requires mobile crisis teams to serve youth exclusively. In terms of availability, most of the BHASOs report that demand sometimes exceeds staffing capacity, although that was reported to be uncommon. One BHASO reported meeting 2-hour response times 98% of the time. Most of the BHASOs reported not having enough member referrals to necessitate additional teams. It would be, but it would be beneficial to have more DCRs. Interviewees cite a shortage of mental health professionals and a lack of peer support specialists. In addition to increased funding, consideration for more flexibility with criteria and staffing requirements for mobile crisis teams in rural areas is desired by the BHASOs. I think I'll skip the mobile crisis team data collection. You can see there's some information there just in the interest of time. So if we can go to the next slide. So I mentioned we did some tribal listening session. We did 1 tribal listening session, and that was done back in September of 2023. Included representatives from the IHCPs across urban, rural, and frontier regions in eastern, central, and western Washington. Participants shared current concerns with timely access to inpatient, including ITA hospital beds, outpatient mental health and SUD services, and response times for crisis mobile teams and DCR services. We kind of categorized the feedback we got. We had issues related to the availability of providers, programming of facilities. There were definitely workforce challenges cited, issues just related to the characteristics of the geographic service area. Almost all the service areas in eastern Washington are rural. It's approximately 40 miles from the nearest provider, and then securing transportation can be a significant barrier. And then we had some other challenges due to stigma. Some families are reluctant to visit local behavioral health providers in smaller communities and express concern that their health information will not be kept confidential. There's also challenges in accessing long-term treatment services in some areas. Members must receive care far from their homes and communities. IHCPs and families experience challenges tracking where the member gets treatment once they leave the community. Next slide, please. So we had a set of recommendations in the report. Again, I'm kind of making sure that we're not going over time here, but in terms of the DCR response times, there was a recommendation to offer DCR services via telehealth to supplement the ongoing availability of DCRs. Probably not ideal to do it virtually, but to extend that resource a little bit. Continue efforts to expand DCR staffing resources and review compensation schedules that may assist with recruitment and retention in rural areas. Based on available funding, offer monetary incentives that might help with job retention, things like bonuses, assistance with relocation, flexible working schedules can be appealing. And then examine current reimbursement policies for ambulance services to assess the feasibility of a bundled payment methodology that would cover the cost for round trips in rural areas. We heard information that that maybe only one leg of the trip is currently covered. Next slide, please. In terms of recommendations for accessing inpatient and outpatient behavioral health services in rural counties, again, continue to promote telehealth options, continue efforts to implement value-based purchasing arrangements, use of incentives, enhanced rates to attract and retain behavioral health providers in rural areas. Offer behavioral health professionals, including Spanish-speaking staff, relocation assistance, and sign-on bonuses to help address the staff shortages in rural areas. And then sponsor and execute a rural behavioral health provider reimbursement rate study, and as appropriate, adjust rates to reflect the current market values. Next slide, please. Recommendations for the hospital bed wait time focus area, continue efforts to develop and implement a centralized statewide ITA bed repository that may assist DCRs and community members to efficiently identify facilities that have available beds. Work with the Washington State Hospital Association and local legislators to review and alleviate reported hospital practices that we heard related to refusing admission to members that are perceived to be challenging. That included folks with high acuity, dual diagnosis, and a history of assaultive behavior. And then enhance the continuum of available behavioral health outpatient services, such as PACT and intensive outpatient services and medication monitoring services that may address some of the extended lengths of stay in acute inpatient settings. Next slide, please. In terms of timely access to mobile crisis teams, offer behavioral health professionals relocation assistance, sign-on bonuses to address the current vacancy rates, offer flexibility in terms of expectations for mobile crisis teams dedicated to serving youth. Many of the BHASOs have adopted a hybrid approach that includes behavioral health staff who are appropriately trained to support adults, adolescents, and children who may be experiencing behavioral health crisis. And then provided a minimum annual training to support and develop law enforcement agencies' understanding of behavioral health emergencies and crises, and provide and support the delivery of CIT training. Next slide, please. In terms of the tribal delivery system recommendations, we understood there were efforts underway to ensure cross-system interfaces that are tailored to tribal populations through the development of a healthcare authority tribal crisis coordination protocol, complete the state tribal crisis coordination protocols, ensuring others working in the crisis system are aware of these protocols, and the development of a native and strong lifeline in Indian behavioral health hub. Continue efforts to develop the capacity of inpatient mental health services by IHSPs on tribal lands, including the development of a culturally appropriate tribal evaluation and treatment secure withdrawal management facility. And then finally, adopt legislation to enhance tribes' ability to provide crisis services to their tribal community members, including notifications to tribes for ITA investigations of tribal members and American Indians with IHCP as their medical home. Okay, that kind of wraps it up. I kind of rushed through a little bit the recommendations there, just given the time constraints, but open to any questions or comments at this point.
Questions for Dan? Malika.
Thank you for your presentation. I was wondering, so did you speak with people that actually use the services? I didn't catch whether that was part of the stakeholder group. I did understand that it sounded like that happened with the tribal interest, but I didn't know if it happened generally.
Yeah, that's a great point. We did not speak specifically to members or family members that had experience with the care delivery system outside of our tribal listening session that we facilitated with the healthcare authority. So those particular insights were not part of this particular study.
Because it would seem like from an accountability perspective, so I'm just gonna drive my point home a little bit further on this. From an accountability standpoint, it would seem like that would be really important to make sure that the investments that are being made are being like what's happening with them, and not just hearing it from the perspective of the people that are supposed to be delivering the services.
Yeah, I definitely agree with that. We've done other similar studies with other states, and I know firsthand that input from individuals that experience the care system is very powerful and very insightful. We worked with the healthcare authority to kind of design the study, and we had some limited time. There were some constraints in terms of the time period, and we ended up with the methodology that I presented.
Okay, thank you.
You're welcome.
Thank you. Any more questions for Dan? All right. Thank you, Dan. Thank you for your presentation. Tony?
Yeah, just thanks so much, Dan and Malika. Thanks for your question. We do have, like within Division of Behavioral Health and Recovery and at Healthcare Authority, we have other teams working specifically on involuntary treatment, mobile crisis team expansion, and crisis response. I'll check with them just to follow up with your question, Malika, just to see if there's been some other efforts to get that sort of participant voice, outside of the work that Mercer did, and then I can circle back around on that. I'll take that as kind of an action item, so I think that's a good point. But Dan, thanks so much for your time, and thanks for sharing the outcomes of that study, and we'll get the information out to those that requested it, along with our agenda and notes. Thank you.
Thank you.
And then I'll just transition to the next one because we are running a little low on time. Thank you so much for being here, Teresa Ciabattari. Sorry if I mispronounced that.
That's all right. That was close.
But thanks so much for being patient and for doing a kind of truncated summary of the 2025 client survey. This is a survey that Research and Data Analysis did for individuals who receive Medicaid-funded services in Washington State. And so we wanted to just provide a quick summary of what some of that information is and share the report with the committee, and then maybe we can take follow-up questions directly to Teresa if there are any. But Teresa, I'll pass off to you and John.
Great, thank you. Thank you. Yes, our plan for today is to provide an overview of the client survey and its goals, to share the survey results for SUD clients, and in particular to highlight some of what SUD clients had to say in their responses to the open-ended comment questions. So first, about the client survey. So the primary goal of this survey is to elevate the voices of social and health services clients. And we work towards this goal in 3 ways. First, we survey a representative sample of clients who receive services from DSHS, HCA, and DCYF. Second, we understand that many clients have complex needs that often cross multiple programs. So we ask clients about their satisfaction with all the programs from which they receive services. And third, we include open-ended questions so that we can really hear what clients have to say about their experience receiving these services. We have been conducting the survey every 2 years since 2001. And as you know, the Results Washington and the Governor's Office is very interested in understanding and improving customer service across government agencies. And this project is in service of those efforts. So our representative sample is made up of over 1,100 clients from 10 programs across DSHS, HCA, and DCYF. And you can see that the largest client groups are in Apple Health and ESA Community Services Division. And it also included 142 clients who received SUD services between May 2023 and April 2024. The calling for this year's survey was between October of 24 to May of 2025. The overall survey response rate was 56%. Many of these incompletes were because we couldn't get a hold of the clients, either because we didn't have accurate contact information for them or if nobody answered the phone. And unfortunately, that is becoming more common as the public trust in unknown callers has increased over the last several years. But when our callers got somebody on the phone, 86% of them agreed to complete the survey, which is very high by industry standards and really reflects the quality and professionalism of our calling team. So turning specifically to the SUD clients, you'll see that they are distributed throughout the states, about 40% each in Region 2 and 3, and the remaining 20% in Region 1. Most of the SUD clients identify as white, followed by Black and Hispanic, and it was evenly split in gender identity between men and women. On the bottom of the slide, you can see that most SUD clients received services from 3 or more programs. The most common overlap was with CSD, Community Services, and with Apple Health, followed by mental health services. Here are the results for SUD clients. You can see that overall, they are very satisfied with the overall quality and helpfulness of SUD services, and they are also happy with their interactions with SUD and with provider staff, right? So for example, 97% of SUD clients feel that drug and alcohol services has helped them and that they're satisfied with those services. 95% say that their treatment providers explain things clearly. 94% said that staff listened. 93% said that staff treat them with courtesy and respect. So overall, very highly satisfied. The lower scoring items are there at the bottom, the question about whether the programs work together across different programs to get services, and that's at 74% positive. And then the second lowest was at 84% positive there in the middle about the timeliness of getting services. But again, I will emphasize that though these are the lowest scores for SUD, they are not by any standard low. As a whole, SUD clients are quite satisfied with their services. So SUD also asked 2 program-specific questions this year. When 96% of clients said that staff gave them information about treatment using medications, and 63% of clients said that they received support through a peer counselor. On the second item, I will mention that a few clients said in their comments that they were offered peer counseling services, but decided not to use them. So this may be a potential area of action for SUD to understand why there isn't more uptake on this service and to think of ways to make it a more attractive option for more clients. So Tony asked about results by region, and I was able to do some supplemental analysis. It's difficult to make meaningful comparisons across the regions or between regions since the number in each region is small and the context in each region is so different. But what this analysis does, it allows each region to really assess where its strengths and opportunities may be. This is showing change over time. So this slide goes back to, again, this is back to the results for all SUD clients going back to 2015. We can see that SUD clients are much more satisfied now than they were 10 years ago. So the long-term trend is overwhelmingly positive. When we look at change from the most recent survey in 2023, there were 5 items that increased, so became more positive, and 8 items that decreased, although it's important to note that none of these changes are statistically significant. So the largest increase was in ease of access to SUD services, which rose 8 points to 93% satisfied. And then the largest decrease was in having phone calls returned within 48 hours, which declined 6 points to 88% satisfied. And here I'll just note that compared to all social and health services clients combined, across all 10 programs, SUD clients are more positive on every question. I want to turn now to the analysis of the open-ended comments made by SUD clients. So in addition to the closed survey questions that we ask for each program that a client receives services from, we also ask open-ended questions where we invite clients to share their ideas in relation to any of the programs that they receive services from. And our team reads and codes each one of those comments into one or more substantive themes and sub-themes, and then also note whether the comment is positive, so it's a good work comment, a kudos, or if it's a negative comment, an area that needs work or needs improvement. So you can see, for example, that SUD clients are very positive about the overall helpfulness of their services. And they also had good work comments related to staff courtesy, customer service, and staff professionalism. Where we see more needs work comments is in relation to access to staff, access to providers, and eligibility and application processes. But again, I'll note here that though we're looking at the comments made by SUD clients, the substance of the comments themselves may be in reference to any of the programs from which they receive services. And as we saw at the beginning, the vast majority of SUD clients are receiving services from multiple programs. So here are some examples of what clients had to say in answer to the question of what they liked best about their services. They are very grateful about the services that they've received. Being a single mom, all of it has been really helpful. The TANF, the treatment, it's all helped me. I'm so grateful. I wouldn't be able to survive without them. I would be a mess if it wasn't for these services. So a real depth of gratitude and appreciation for what the services offer to them. They also are positive about staff, right? The staff understand and are supportive. The counseling was helpful. They want you to succeed. And there's one comment here in the middle about the timeliness. Everything happened within a week. Everything was perfect. You don't see that very often. And they have successfully finished the program. Turning to some examples of what clients had to say about what they'd like to see improved, there's kind of 3 general categories of improvement. One is about staff availability and having staff who understand. So giving staff more time to interact with clients, hiring more caseworkers, having a night team available, having better communication across program staff, and then having people who understand what they've gone through. A second set of comments is related to treatment locations and availability, such as in rural counties and just needing more services in general. And then finally, there was a set of recommendations or a set of comments that were sort of about specific sort of policy pieces. So for example, how you get assigned to a location. They do by zip code, but that's not necessarily the closest, or the way that medications are distributed. And then finally, this is a word cloud showing what clients said most frequently within each of the themes. And again, these comments could be related to any of their services. Okay, well, so I'm happy to take questions now. I know we're getting to the closing of the meeting, so you are also welcome to follow up with me or John with any additional questions.
Teresa, just given the time, I think, can we share these slides with the group and then just take any sort of follow-up questions just individually at that point?
Absolutely. Absolutely. I'll send the slides to Michelle. And then I believe all of you also have access to a one-pager that is a summary of results as well.
That'd be great. Thank you so much for being here. And
No,
sorry
you bet.
that we ran out of time and that you had
No
to shorten
problem.
that. But great information, and we'll make sure and get that to the committee.
Great. Thank you.
Thanks, Teresa.
Okay, well, we have about 4 minutes, and there's a couple things I wanted to talk about real quick. One is a comment that Caleb made earlier in the meeting about using the term addictions. Made some good points, and I think we'll set aside time at the next meeting to discuss that as a committee. I think there's definitely some pros and cons, and I know we've had conversations about this internally at HCA, and so I appreciate Caleb flagging that. Also wanted to just kind of acknowledge at our last meeting, at the conclusion of the last meeting, Representative Davis had some really good recommendations about how to use meeting time going forward. Obviously didn't really have enough time to kind of pivot and adjust the way that we structure the meetings for this meeting today. And so it was another meeting where we had a lot of information being shared with the committee, but not as much of an opportunity for any sort of kind of dialogue or like talking about some of the key issues that we're seeing in relation to the substance use recovery services plan. And so I did want to just take a second and acknowledge that feedback and, just indicate and share with the committee that we have been discussing that internally about how best to operationalize committee meetings going forward and try to ensure that there is some sort of time or some sort of mechanism in place where we can hopefully elicit more thoughts, opinions, experiences from the committee members as it relates to what is within the substance use recovery services plan. And so hopefully for the next meeting when we come back in August, we'll have some time dedicated on the agenda to do that. And just appreciate that recommendation and just the idea about getting some more active dialogue from the committee members, because it is such a great group here and bringing expertise from all over the state, from different lived experience and working experience. And so we will be trying our best to create those opportunities going forward. And with that, we'll be also doing it with reduced resources because as a reminder, back when the governor's proposed budget and the budget discussions were ongoing, most of the state agencies were directed to identify a 6% reduction in overhead costs and costs associated with doing the work. And the healthcare authority is identifying how to do that. As part of that process, we decided not to put out a recruitment for the SURSAC administrator position to help kind of contribute towards those agency reductions and trying to figure out how we can make up that 6% in a reduced budget across the healthcare authority. And so going forward, Michelle is going to obviously support, and Tim Candela from Department of Health is always here helping support as well, and Rachel and then myself. We'll just wanted to kind of flag that for the committee that this will this is still a priority. This work is a priority, and within the budget environment, it just didn't make sense to kind of recruit for a position, especially considering that the committee sunsets December of 2026. And so having to make difficult budget decisions and figure out what makes the most sense for the agency as a whole, as well as the division as a whole. But I think we still have a lot of different people that are able to help support the work, and we'll definitely make sure that we continue to have these good conversations and we have time dedicated, and we'll continue to provide the updates as well. With that, are there any? Well, we're at 11, but any questions or comments from the committee? And then if none, we can also take questions from the public or comments. Okay, I think I paused long enough. Thanks again to our guests today, our presenters, for sharing that great information. We'll get the resources out along with the notes and the recording. All that information is posted on the SURSAC webpage as well, just as a reminder. And appreciate everyone's time today. And we will we'll contact the committee members sooner than later about the August agenda. I think right now we just have a couple of things that were previously planned, such as an update about from our lead support bureau partners, the third part of that series. And then we'll also figure out where else we can kind of focus some of our attention for the August meeting as well. So thanks so much, and take care, and we'll see you next month.